Hi, it's Jenny from America. Nowheresville, America, I should say, from our hillbilly state. Just wanted to give you some more information. There was a wonderful commentator a few days ago that let me down this path, and whoever you are, thank you, thank you, thank you. Basically, you wanted me to kind of give you an idea about what is acuity and what does that mean, and why should there be just a one-to-one nursing for babies or a two-to-one, two babies to one nursing situation? I'm going to give you that explanation here, but I'm also going to give you an explanation on the app cars too. And basically the app cars, it drove me nuts when I read the trial testimony, because what they are saying is, well, this baby's app cars were this and this. And the prosecuting attorney was saying, oh, well, that the app car is a predictor for long-term issues on the baby. It is absolutely not. What it is, it just tells you right now what that baby needs. Right now, does this baby right now need immediate resuscitation measures? And also another thing, a very, very important thing about an app car is that it is what we would call subjective, meaning I may give this baby 2 points for the way it appears. If you look at the skin color right here, I could be an experienced midwife. There could be two of us in there. I might give it a 1 point where that other one would give it a 2 points. So just remember that is absolutely subjective. Now these APCAR scores, again, it comes from the 1950s by a woman by the name whose last name was APCAR. That's why it's called APCAR. And these are taken at 1 and 5 minutes, and I think sometimes they may take it a third time, but I cannot remember exactly what that is. And basically what you're going to do is you're going to look at this baby and you're going to give it a certain score. And obviously the higher the points, the better it is. The best thing you can get is a 10. I've never heard of a baby ever getting a 10. It is that rare. Basically, if it's depending on how limp it is, well, if it's got a flexed arm or if it's moving, well, it's going to get a 2 point versus flex, it's going to get a 1. And that is where you get a 0 if that baby is limp. That's bad. And again, what's the pulse? If they're going to listen to the baby's heart through a stethoscope, if it's less than 100 beats a minute, they're going to give it 1 point. If it's greater than, it'll be 2. And then you can kind of see these basic things here. Now, also keep in mind that immediately when that baby is born, it wants to do whatever it can to survive. So its bodies are going to put out like adrenaline stuff, and it's going to do whatever it can to survive. So in fact, all the time, well, not all the time, but most of the time, these little tiny preemie babies, they can come out crying. They can be really premature, but boy, they are crying. But boy, that reserve is used up very quickly. And, very relatively soon. And even after that 5-minute APCAR, it's going to run out of reserves and it's going to need resuscitative. So just because those APCAR scores, well, it was a 7 and then it was a 9, means diddly squat, all right, when it comes to the trial for Lucy. Now, granted, to some degree, yeah, if you got a full-term baby and it's got a really good score, you can pretty much, predict to some degree that, and mom doesn't have any, again, this is where the obstetric history comes in. Mom is not diabetic and doesn't have all these other obstetrical history conditions that I've been mentioning. And basically, is a good weight and the whole bit, you can pretty much rest assured that there's a really good chance that this baby's going to be just fine. Again, but you know what? It's not perfect. Again, even the best situations, even the best looking baby that comes out, it can literally within hours all of a sudden become hypoglycemic. Or again, the baby is having to adapt from swimming in amniotic fluid and not using its lungs to all this, and having certain passageways, I want to say holes, passageways in its heart that that does really well during fetal life, but all of a sudden it's now out in the environment. And again, when those passageways and holes start to kind of close up, that's when, and it could be a day or two later, that is when all of a sudden, if this baby has an underlying heart condition that we just didn't know about, something's going on with the structure, that's when it would show up. And another situation is sometimes these little babies, again, when they're born, they just long to be the laziest little turkeys on the face of the planet. And it's not unheard of for these babies to, basically that 1 minute APGAR looks really bad. And so once they all of a sudden give us a couple of rescue breaths and stuff, and it just pinks right up and it does just fine. Again, this is where we would call the art of nursing or the art of medicine comes in. It's not exactly a score. Through experience, through education that this baby's going to be fine. Now, let's look at this. Now, this is where they would statistics comes into play. It's very, very important. Now, I am not trying to in any way denigrate statistics. There is an absolute purpose for that. We have to have some sort of a baseline. We have to have some measurement, some way that we can do various research things. And we can kind of, to some degree, very much predict what, on average, what would happen. We know on average that a certain a ratio of certain number of nurses that would be needed on a certain shift and on a certain day would be. The problem is it just gives you the average. It doesn't give you what you would call the outliers. And basically what I mean is an outlier, if you ever see a statistical thing, you'll see what they call a bell-shaped curve. It's going to give us that good measurement that's right here in the on the thing. It doesn't tell us what these end numbers are. And you always have to be prepared for whatever the outlier is. And another situation that there's a problem that we've run into is that babies just don't like to crash right before, or have an issue right before a shift would begin or end. And that, an hour or two before a shift would end is when you're going to predict what you think you would need for the incoming shift. And again, I was toward the end of my career when I was a hospital nurse, I was what we would have called a band 6. And I would have to call down to the supervisor and give her a certain number, give her a certain thing as okay, on the next shift, we're going to need this many amount of nurses because we have this going on. And I would have to prove to her to some degree that, Joe Blow in room whatever is a 3, and that would predict, or, we would be able to use a number to predict. Granted, what the problem is that you have to, again, this is where the art of nursing comes in, is that even though, let's just say, Joe Blow in room whatever has a number of 3, I can look at him and I just know, even though I can't prove to you on a number scale that he's going to crash, I just know in my heart, in my gut. And that's where if you have a good supervisor and is willing to fight those bean counters and say, okay, I'm going to give you that extra nurse. Just because, I know, that, and we know in our gut, we know in the art of nursing, we know that the chance that something's going to go wrong in that next shift, or you just need that extra nurse, that extra body on the floor so they can keep a good eye on that, and just notice those tiny subtle differences that literally would make all the difference in the world whether that patient could live or die. Now, what what the NHS was doing, it was borrowing and using, and I actually don't blame to some degree the NHS using our American systems, because why invent the wheel, and adapting them to whatever situation is going on with this. All these numbers that I'm giving you here are good research bound, good use evidence-based medicine, evidence-based research, good statistical measures to say. And again, we give a baby a certain number. And that's going to tell us, first of all, that's going to tell me as the chart auditor what I'm going to tell the insurance company, how I'm going to be basically reimbursed. Just because a baby is in the neonatal intensive care unit doesn't automatically mean that we're going to get whatever that set number of dollars are. They're going to pay us to how sick or unstable that baby is. Because we know, the more unstable the baby, the more the nursing care and the more, lab it's going to need and monitoring it's going to need. So it's going to give us more money versus if that baby is, close to discharge. Well, there's no reason for us to give you that high dollar amount. They're going to give you more the base rate. So what we do is, and again, remember, if you can recall, the neonatal intensive care unit at the Countess of Chester was 4 rooms. It was 4 levels, meaning, room 1 was the highest level, and then down to room 4 was the lowest level. And probably in that room 4, it was what we would have called, feeder growers, babies near discharge, or baby just needing an overnight stay. And again, that nursery nurse, or that registered nurse may have been able to handle 4 babies at a time, if it was such a stable baby. Again, we're going to give you numbers. And sad part is, though, again, the bean counters at the hospitals, the bean counters that are not the, shall we say, the foot soldiers, not in the trenches, they live and die by these numbers. And they don't allow for the art of nursing and the art of medicine to interplay on this. It's just for statistical reasons, for staffing levels, and there is no give and take in this, unless you have a supervisor, a direct supervisor that is willing to fight this. And the problem is that unlike days of old, what they do is, again, these are people that are high level. They're not in the trenches. Many of them don't even have any medical background. They have a business background. They're going to promote people that are going to go with the flow, are not going to fight the statistics, are not going to want to be hermetically sealed in their offices and just basically punching numbers. Those are the people they're going to promote. They're not going to promote the fighters, the drill sergeants, those lieutenants, those low that are really going to fight for those soldiers that are in the trenches, those soldiers that are really face whatever is needed and are really fighting this battle. So let me explain to you what this is. Basically, there are certain rev codes. And you see this word revenue, we call them rev codes, but a revenue code. A 170 would basically be a baby that would be at the bedside with the mom and has no reason to go enter in a neonatal intensive care unit. But still, that baby is being importantly monitored by that a postpartum nurse, that a midwife. First of all, she has to monitor the mom to make sure she doesn't have postpartum complications. And second of all, she has to monitor that baby. There are certain set protocols that she's going to do. She's going to do a little heel stick and make sure its sugar's doing fine. She's going to listen to its heartbeat and count its respirations and all these various things just to make sure that that baby is doing fine. Those days while it's still in the hospital with the mom. And again, and she is very skilled, very knowledgeable, and able to basically call that pediatrician, and I have seen these midwives and postpartum nurses physically take that baby, grab it, and run it into that neonatal intensive care unit, and get that emergency situation. So very important. Now 171, basically what you would do is all you would have to do is basically meet one of these, and that would buy you in the shall we say room 4 at the Countess of Chester, which would be the lowest acuity, and that would be just okay. Oh my gosh, this baby's hypoglycemic. It's going to need some glucose, because it's not, again, it's not so much that it's going to need glucose that's important. It needs that glucose immediately. It also needs to be monitored for certain very, very important signs and symptoms of low glucose. And again, what's happening is you want to make sure that you watch that, because that baby, if that brain runs out of energy, it's going to seize. It's going to get brain damage. Okay, so again, another, it would just be a root. This is a baby that's going to need some routine blood tests. You want to keep it, again, you want to have eyes on that baby. It's going to need, basically, it's physiological stable infants. And again, none of the babies in the Lucy trial would be considered physiologically stable. It's not needing oxygen. It's barely needing any medication. It does not need heat. It's able to maintain its body temperature with just a little hat on and a couple of blankets wrapping it. It's all you're having to do is just monitor and make sure it's gaining the weight, and you're advancing those feeds with a bottle, not a tube. Remember, just a bottle. Doesn't need that tube down into its stomach to pour that milk down in it. And it's basically, you are close to discharge. Now, the only time, occasionally you might have a baby in there just temporarily. It just might need a couple of hours under a heat lamp per se, or wow, it's a very stable baby, but it might have some sort of what we would call a stable congenital situation kind of going on. You know, you want to have eyes on it in a children's hospital, because it down the road it's going to need to be monitored for a very stable condition. But again, you would want those specialized eyes on it, because again, at the Countess of Chester Hospital, you would not need a neonatal cardiologist, or a certain type of surgeons and such stuff like that. A neonatologist. And even a pediatrician, this baby wouldn't need a neonatologist. It would just need a pediatrician. Now, again, with this, what I would call Rev Code 2, this would probably be a baby that would have been in room 3. Now, what's really important, all it has to do is meet one of these criteria, but this is one of those conditions. If it would meet 3 of these, you could bump it up to room 2. All right. Tube feedings. That's that tube that's going down into the stomach that do it, and that's basically what that is here. Apneic are those periods where they just don't breathe real well, or they have short periods where they just don't breathe, or periods where their heart goes down. Again, that's a sign. You want to keep an eye on that. The apneic or bradycardia could be just a sign it's premature. Its brain's not telling it to do everything it should do, or it's basically you need a certain level of certain brain maturity just to tell that baby, okay, breathe. And sometimes these brains are immature, but it also could be absolutely a sign of impending doom. You just don't know, so you want to keep eyes on that. Hypoglycemic, again, this wouldn't just be a baby that, okay, just give it a little sugar water, or feed it, in a bottle. Sometimes you have to actually push that into an IV. A sepsis evaluation. Yeah. Again, they're not septic. You just have this feeling that they could be or headed toward it. And you absolutely want to just do you got to have eyes on it. You want to do a certain test. It has not reached the threshold of sepsis. It's just like your gut is telling you. That's where the art of medicine comes in and the art of nursing. Certain intravenous medications in the IVs. Certain, again, sometimes a baby might need just a little shot, and it's just like a little shot. Now, and with the total parental nutrition via a peripheral line. And when we say peripheral line, it's a little line, it's either in its foot or its hand. Exactly the same time of IV line you and I would have if we would need to suspend a short period of time in a hospital. And there are certain low, not high, high, it's not volume, a concentration of fluids, a little bit of higher level sugar, few little vitamins, you can give it to that just to kind of give it a boost. This is very important right here. That's just basically what this is. Don't worry, it's just a little hood. Or basically, when we talk about nasal cannula, that's the same thing you and I would have if we were in the emergency room for a short period of time, or in the hospital for a short period of time, and they put that little oxygen in your just that little nose of yours. This is very important. 3 liters. That's very important. Babies are really kind of weird. You give them too much oxygen, essentially the oxygen physiologically can act like a poison. It's dangerous. It can lead to a lot of bad things. Neonatal abstinence syndrome, that's withdrawal. If the mom was on certain medications, especially if she abused drugs, or even if she was a chronic pain situation where she would have to take for opiates for a medically reason for a chronic pain situation, that baby essentially is, hooked on those opiates, or could be whatever, benzodiazepines, and the baby will go withdraw, and you really have to monitor. That could be a very serious situation, and there's certain scores you would give it. Again, if a baby has too much jaundice and requires what we would call billy lights or billy blanket, again, their little livers are immature and stuff, so generally they will get jaundice. Now, what's really important here is that when does this jaundice appear? If it's 24 hours or less, that means something is destroying that baby's actual red blood cells. If it's a little bit later on, it's just not being able to filter things like it normally would be. Again, their liver needs to mature a little bit more. Thermal regulation, it just means that you're weaning it. You're at that process where you're lowering those temperatures in an incubator so it can then basically soon, and hopefully soonish, it's getting to that point where it's going to just be able to tolerate being out in what we would call an open cot. Just a regular old cot, and just a couple of blankets and a hat on it. It's going to be able to handle it. Again, here, look at this. Needs a consultation. All right, you're waiting for that consultation. Something's going on. You're waiting for that doctor to come in, that specialized cardiologist, ophthalmologist, whatever. Something's going on that baby. You need eyes on that baby. You're just waiting for that doctor to come in and do what they need to do. And basically support for an unstable neonate. Again, you need eyes on it. It's not a super unstable baby, but it's unstable enough to where you're waiting for that transport team to come in. And again, there's certain congenital conditions and other conditions where it's not, it's not immediately life-threatening. You're just waiting for someone to come in, and so it can get that higher level of care. Now, again, if you would meet 3 of those, you're going to bump all the way up to that, and that might even be what we would call this might be closer to, maybe the nurse has 2 or 3 babies to one nurse. Probably closer to how much, if it only has one of these things, and that nurse each baby only has one thing, she probably could handle 3 babies in that situation. But again, if a baby has 2 of these or more, okay, now we're thinking on, and this is where the art of nursing comes in. It might just be, you might want to consider having just the nurse having 2 babies instead of 1. Now, this is where we're getting into the kind of more the hairier situations here. A Revcoat 173. Look at that, 32 weeker. Look at the weight on that. Remember, baby E was what? A 13-gram baby, all right? Certain IV medications, and again, certain fluids that they need, or they may need, they're not, you're not liking what they're taking in. So you want to make sure, and it's very, very vital that you don't give this baby too much IV fluids. You can so overload their heart, and basically just their heart goes into absolute failure if you fluid overload them, and their kidneys will shut down. It's an absolute life-threatening situation. Seizures, look at that. Now, granted, in my unit, we would never, that would automatically, we would be waiting for a transport for that one. Apneic, and again, apnea bradycardia, well, there are certain things that you would actually, instead of giving this baby, and yes, you give it caffeine. If it was at that 172, you could just give it a little bit of oral caffeine. And this you're going to want to push that caffeine medication into that IV on that baby. Again, look at this right here. Now, this is a this is a much, much higher level. Again, this baby cannot or is barely taking in enough orally. You got to give it all the nutrients it needs in IV line, and you can't give it into its little hand. You can't give it into its little foot. The concentration are too high. The fats are too high. You have to give it into what we would call a central line. And these are those umbilical lines, or this is that long line right here. That was that for that baby A here. And again, this is really sad in this situation. If you remember baby A and B, that was with that mom. Again, they did not look at that obstetric care in that baby. All these babies kind of needed was a little bit of oxygen situation. It only had a peripheral line. It didn't have this here. So they might have even just put that at that level. And that poor nurse had too many babies. And again, we know now with baby A and B, that mom had such a really profound obstetric history that needed one-to-one care. Even though technically the trainees didn't get around to putting in this these lines right here. In fact, I believe that those babies probably needed something what we call a UAC line, and that is a really, really important line that you would use for certain invasive monitoring, meaning you have a continuous monitoring of the pulse, of the oxygen level, of the blood pressure, and certain other very, very important vital signs that you want to monitor. So this baby's, again, they didn't meet what you would call criteria because these trainees didn't know that it needed to be monitored. And again, this baby was overnight, that first shift in fact, the first two shifts, that first 12 hours of those babies' life, it was not being monitored close enough as it should be. And in fact, they didn't get this until later on that day. And after that day shift started, again, if you're going to want to have that nursing, it has to happen before that shift. That's when they determine the shifts coming in. It's rare for you to be able to call in a nurse at the last minute. What nurses, they're already put in enough hours as it is. Few nurses are going to come in. Lucy was the exception. She would come in at a moment's notice, but how many people can drop what they are doing and come running? You can't, all right? So you got to go with whatever. Now let's look at some other, again. Oh my God, look at how many babies needed blood transfusions. Look at that. Non-invasive ventilator support. This is just those, you hear CPAP? That is a very important, you're gonna wanna watch that. The next step on this would be the tube down into the windpipe. Again, you gotta watch that. And again, look at that. They're regular nasal cannula, but it's above 3 liters. Again, you have to watch those babies. If you give them a certain amount of oxygen, you gotta watch them like a hawk. Look at this. Now, invasive ventilator support. This is, again, we would have never had a tracheostomy on that for that situation. This is the tube down the windpipe. But these are babies that are very, very, very stable. They are premature. They're unable to breathe on their own. They needed much more higher ventilation support, and basically they're going to need probably they're going to need to be on that ventilator, but they're very stable in that ventilator, and they need days or weeks on that. Again, those are the stable babies. None of the Lucy's babies that were on ventilator support, they were on immediate ventilator support, live ventilator support. It wasn't more or less this kind of more like long term until they grow high enough. Or you even a baby that is post ventilator care, you're able to move, like my daughter. They were able to remove that tube within just in first few hours after her life. But again, she was closely monitored for a very high, that first day. Various just various airway protections. There are certain babies that have congenital conditions in their face, and they need certain airway protections just to keep things open. Chest tubes. That's, this is the thing where Ravi messed up on baby H. Surgical intervention. We didn't do surgery where we are. We would transfer that baby to the children's hospital. But again, basically, this is where Alder Hey had a lot of this. Alder Hey was this surgical site for the high level if the baby needed surgery, and Liverpool was the medical. But occasionally, they would keep these babies up a couple of days after general anesthesia just to keep it on. They had what they would call a neonatal intensive surgical unit for those babies. Again, these are certain eye situations, very, very important. There's less blind individuals right now, only because now that they were able to catch certain eye situations very early and prevent that blindness. Neonatal eps, again, if you got a mom that's withdrawing, but they have a high enough score, again, a real severe withdrawal, an early withdrawal, you have to do it. And again, here's that very, very important central lines. You keep an eye on it. And peritoneal dialysis, we wouldn't have ever done that. Withdrawal of life support, very, very important. Even though that baby is going to die or has a very limited life expectancy, still needs a lot of care. It's going to need maybe probably some morphine, but even more importantly, those parents are going to be with it. It's going to need that nurse, that pediatrician, that doctor with those parents for that emotional support, which has to be the worst day of their life. And this is the high. This is the high level. This is again, so many of these babies at the Countess of Chester needed this. The only time they would have ever needed this level of care was in an emergency situation. We are waiting for that transport team to come. They are on that way. We've got to give that absolute life support for that until they can get here. But oh my God, some of these invasive hemodynamic monitoring, there were babies that required horrendous intensive care medicine to keep its blood pressure and its heart going. A high ventilation. Again, maybe you're gonna hear a story about baby O. That register put that on high thing, and it's why its belly blew up. Oh, ECMO is, oh my God, that is a heart-lung machine. I'm assuming maybe Liverpool Women's Hospital has that. If not, definitely this is one of those things you would helicopter a kid into Great Ormond Street. Oh my God, this is if a severe brain damage, dialysis, coma, CPR in the last 24 hours. Or how many of these times did these babies crash and they still kept it? Then it needed CPR, and then it needed another CPR. They kept it. There was no transportee coming. And oh my God, there was so many of these babies that needed this. And I'll explain to the babies that needed this. Michael McConville was absolutely apoplectic, if you would listen to any of his podcasts, that is, you are paralyzing that baby in order to put that on life support, and they were keeping them. The fact that these registrars were using this medication, my God, again, these registrars should have been nowhere near this. That's the stuff. This is the stuff when you need belly surgery and you need to be put out under general anesthesia. You paralyze them. First of all, you paralyze that person, so you absolutely, totally, they are totally dependent on you breathing for them and on that machine, that anesthetist, that anesthesiologist. But also, you've gotta make sure that their muscles are absolutely relaxed, so that surgeon can really get into that body and do that surgery. This should only be under the most extreme of such circumstances. And oh God, and again, I'm going to give you the story of baby I was given this medication. Inexcusable. So again, and these definitely would need a 1-to-1. Many of these babies, again, these nurses were having to deal with this kind of crap, and they also had another baby, or they had another baby that was in another room. I mean, you're talking not a safe situation here at all. And again, Brewery was using these numbers. And again, statistics, it's okay to have these numbers as a baseline, to just at least make that baseline, but you have to add in, again, you have to have enough, to some degree, a little bit of extra wiggle room here, because this baby is going to crash maybe an hour or two into that 12-hour shift, and you need all hands on deck. Again, Lucy often had to come running and assist because she was the only one that knew how to deal with this stuff. Very few nurses on that unit knew how to deal with this stuff. She did. And if she wasn't assigned that baby, well, guess what? Those babies that she was supposed to be taking care of, they weren't being taken care of during whatever that resuscitative thing. They were basically left, oh God, possibly to nursery nurses, again, who didn't have the skill level. They were basically taking care of the feeder growers, the ones that were close to the thing, and they were being forced to monitor the babies that needed that other level, and that is not a safe situation at all. You have to be prepared like a war. You have to be prepared for the incoming bomb that's going to happen, the incoming bullet that's going to happen. And again, and it happens in the United States as much as it happens in the NHS. These bean counters, they want to go. They want, because the highest cost of a hospital is usually the cost of labor, which is essentially is mainly nurses. They want to cut to the bare bones, and they don't want you to. They don't want those soldiers that are in the trenches to be as prepared as possible. And what happens is you're going to have people that are dying. So any concerns or questions you would have, please, if you need me to do even more a deep dive into anything you are seeing right here, you just let me know. I'll be happy to do it. Anything else, again, you are giving me the most incredible, wonderful suggestions to do. And I am gonna, on my thumbnail, I'm gonna put a quote on, and I'll let you read on my thumbnail. It was, I'm stealing it with her permission, a wonderful commentator who just left a comment on a previous one of the videos I did that is just perfect. It explains everything. And that's all you need to know when it comes to the trial of Lucy Letby. Just read my thumbnail. You'll get it. Bye-bye.